The AADSM first published its standards for dental sleep medicine for screening, treating, and managing adults with sleep related breathing disorders in 2018. The paper was published to outline best practices for dentists trained in obstructive sleep apnea. Since 2018, the field has continued to evolve and advance. And as such, we felt a need to update the standards based on a review of more current literature in the field and the consensus of clinical experts. The standards also rely on several positions previously postulated by the AADSM. As we developed this update, we also considered how dentists are best suited to help patients get treated for sleep apnea, especially those who have abandoned other treatments or those who may live in areas in the country in which there may not be adequate access to board certified sleep medicine physicians. In this video, I will cover some of the main concepts of our new paper. It is important to keep in mind that while these standards were developed to assist you, each practice varies, and depending upon the needs of our individual patients, laws and regulations of the state you practice in, and the referral relationships in your community, you may need to modify and adapt your practice to your best clinical judgment. Concept number one is this idea of key competencies of a qualified dentist. As patients and medical colleagues seek oral appliance therapy, it is important that they should seek care only from qualified dentists and ABDSM diplomates. To promote higher caliber levels of clinical treatment, we have outlined 5 major competencies in this paper: clinical knowledge, patient care, learning and improvement, professionalism, and interpersonal and communication skills. These competencies demonstrate that we, qualified dentists, know what we are doing. We provide excellent patient care, we seek continual education, and are guided by ethical principles and effectively communicate with patients and other healthcare providers. As you seek patients, build referral relationships with others in your community and insurers, you may wish to refer to this paper to help explain your demonstrated competence. Concept number 2, qualified dentists may choose to order or distribute home sleep apnea tests. If patients are suspected of having OSA, the standard paper outlines that qualified dentists can order and administer home sleep apnea tests, with the caveat that the patient should be an appropriate candidate and in accordance with applicable laws. I think it is important to mention several things with this. First, this is by no means a requirement. You do not have to order, you do not have to administer a home test. The qualified dentist should also feel comfortable referring the patient to a medical provider for sleep testing if that is the model that you are most comfortable with. Number 2, regardless of how the patient gets a home sleep test, interpreting the home sleep test data and diagnosing OSA still remains under the purview of licensed medical providers for initial diagnosis and verification of treatment efficacy. This position aligns with the ADA policy on sleep-related breathing disorders, which outlines that ordering and administering sleep apnea tests, which may include home sleep apnea tests, is within the scope of dental practice. Concept number 3, qualified dentists can prescribe oral appliance therapy. The AADSM believes that qualified dentists are the only clinicians with the knowledge and skills to determine if a patient is a suitable candidate for an oral appliance, and are therefore the best healthcare providers to prescribe an appliance. Now, insurance policies may not always agree, so anyone submitting claims to insurance or Medicare will absolutely need to follow those requirements. But once a patient has been diagnosed by a licensed medical provider, with the exception of a few states, there are no regulations prohibiting trained dentists from prescribing an oral appliance. We believe that qualified dentists can prescribe an oral appliance in cases where patients have a physician-confirmed diagnosis of OSA and have elected to discontinue or abandon active PAP treatment. In each of these instances, OAT initiation should be communicated with the medical provider. The dentist prescribing an appliance is not meant to remove the medical provider from the patient treatment pathway. Instead, it is meant better to include the medical provider at more critically necessary time points. In this way, we can reduce the time burden need for medical provider and improve outcomes for the patient. The need to prescribe oral appliance therapy will likely vary on access to care in your own communities. May vary as patient needs and your relationships with physician providers as well. As with all parts of this guideline, you will need to use your own clinical judgment to decide if this is something you wish to implement. Concept 4, patients should not take their own impressions and protrusive bite records. The standards outline that qualified dentists are responsible for taking accurate physical or digital impressions and a protrusive bite record. Although technological advancements may allow for it, and the allure of convenience may lead patients to request it, patients do not have the necessary training to take impressions or bite registrations. Impressions by qualified dentists ensure accuracy and precision, reduce costs and treatment delays associated with redoing inaccurate impressions and measurements, and ensure the fit and comfort of custom fabricated oral devices. Concept 5, identifying the appropriate therapeutic position of an oral device. This can require or may use multiple methods. Within 30 days of appliance delivery, the patient should be evaluated and reassessed for signs and symptoms. The important takeaway from this is that the same questionnaire and or tools used at the initial assessment should be used for these reassessments. Some qualified dentists may elect to use resolution of signs and symptoms. Others may elect to use objective data with pulse oximetry, high resolution pulse oximetry, home sleep testing, or PSGs. Regardless of the method, once the appliance is in a therapeutic position, the patient should be referred to the medical provider to verify treatment efficacy. It is also important to note that this concept of the appropriate therapeutic position is one that not only achieves improvement of signs, symptoms, and objective indices, but it also allows the patient to use the appliance comfortably on a nightly basis. It is possible that a medical provider may deem that the optimal position may in fact be subtherapeutic. In those cases, we should make every effort to work with the medical provider to discuss further calibration, adjunctive treatment, or other alternative treatments that can help the patient meet their individual goals for therapy. Concept 6, follow-up care should include monitoring and adherence. The standards suggest that we should evaluate patients every 6 months during the first year after appliance delivery and at least annually thereafter to verify efficacy and resolution of symptoms, assess occlusal stability, document and address any potential or possible side effects, and check the structural integrity of the appliance while monitoring comfort and adherence. When evaluating compliance, the AADSM suggests that the appliance be worn at least 80% of the night and at least 5 nights per week. Patients should also be educated on the idea of obtaining at least 7 hours of sleep per night and wear the appliance for the duration of their sleep. Patients should be categorized as either fully compliant, improving over time, or non-compliant. Those non-compliant patients should be referred to their medical provider to consider alternate therapies. Now, while I haven't covered every portion of these new updated standards, I hopefully have given you a general overview of some of the major concepts that have been revised in this version of the standards. Like every field, DSM will continue to evolve, and I have no doubt that this paper will be updated over time. In the meantime, I hope that it does provide you with some guidance as you begin to look at how to best manage your patients with obstructive sleep apnea. Thank you.